My name is Cecilia Arana Yi. I am a hematology faculty at Mayo Clinic, Arizona. I am here with my colleague, Dr. Jeanne Palmer, hematologist and transplant physician from Mayo Clinic, Arizona, to answer any questions, any concerns that you have in relation to the three topics that we are going to discuss. The first topic is related to acute leukemias or acute myeloleukemias. The second topic is related to myelodysplastic syndrome. And the third topic is related to myeloproliferative neoplasms. And there is a final topic, which is transplant, bone marrow transplant. We are here to answer all of the questions that the audience could have.
I just will echo that. I'm Jeanne Palmer. I'm one of the hematology and transplant doctors here at Mayo Clinic. And this is a very new format for us, so we're just trying to get used to it, but we look forward to being able to answer any questions or talk about anything on these topics that we're able to help with. So now, first of all, are people able to, are they unmuted and able to answer questions or ask questions, excuse me?
Yeah.
They're doing it through the chat and the question and answer. So are you ready for their questions at this time?
Yeah.
Okay, so anyone that is participating, please go ahead and drop your comments in the chat or the question and answer box. It looks like we've got one right now to start. The question is, I thought I signed up for neuroendocrine cancer. I was diagnosed with a second lesion in my breast as neuroendocrine differentiation and was told this is the same as cancer. And if it is, there is little to find neuroendocrine in the breast.
Well, as a hematologist, this is probably not something that I could answer. I don't know if there's another breakout session that is for neuroendocrine tumors, because I know there's definitely nuances to neuroendocrine tumors that I would probably not be able to effectively answer.
Sure. There was one yesterday, or actually on Monday. There was a neuroendocrine session.
I'm really sorry that I wouldn't be able to provide much insight on that.
Yeah, it's again, it's not our field of expertise, unfortunately, and we don't want to provide information that we are not 100% sure. But thank you so much for the question. Thank you very much. Yeah. So perhaps, Jeanne, while we are waiting for the questions from the audience, maybe we can provide a brief overview about what is MDS, what is AML, what is myeloproliferative neoplasms. And I would like to start with a brief introduction about what is acute myeloid leukemia. So acute myeloid leukemia is a type of blood cancer. And the blood is the same as other organs and system, is another tissue that is in general inside of the bone marrow, and the bone marrow is the tissue inside of the long bones. This organ is in charge of the production of the normal blood elements, and we have three important blood elements: the red cells, the platelets, and the white cells. When there is a problem in the production of the blood elements, we do consider that maybe there is a problem in the bone marrow. An acute leukemia is as simply as the abnormality in the production of the blood elements. So instead of the blood, the bone marrow producing normal blood counts, they start to produce these abnormal cells that we call blasts or baby cells that unfortunately start to grow without control. And as a consequence of that, the other three blood elements that I already explained are unfortunately produced in less numbers. And as a consequence of that, patients can have anemias, talking about feeling very tired, predisposition for heart problems, lung problems because they are short of breath. They can have low platelet counts, and as a consequence of that, patients can have spontaneous bruises, spontaneous bleeding, especially when they are brushing the teeth or blowing the nose, or when the white counts are low, the predisposition for infections. It's not unusual for patients with acute leukemias to get admitted to the hospital right away because of a very bad complication, and then to make the diagnosis of acute myeloid leukemia in the hospital. There are different treatment options, and certainly one of the treatments that cure leukemias is a transplant. And I believe there is a question for the audience about transplant. Maybe Jody would like to read the question.
Sure. What is the difference between Auto and Allo Bmt? If you have an Auto Bmt, which oncologist collects stem cells from cancer patients' stem cells, then they will relapse sooner or later. Do you kill all cancer cells from patient stem cells before transfusion?
So I think Dr. Palmer will be answering this question.
So just to kind of back up a little bit, when we talk about bone marrow transplant, what we talk about doing is to collect stem cells from the bone marrow of the person, or collect bone marrow stem cells. Now, these are hematopoietic stem cells, or stem cells that will make all the blood system. They only live inside the bone marrow. There's two different types of transplants that have kind of two different types of endpoints. The first one, as mentioned here, is autologous stem cell transplant. And what that is a way to, how we approach an autologous stem cell transplant is the stem cells are collected from a person, and they're collected out of the bone marrow by giving medicines that help the stem cells leave the bone marrow and go into the peripheral blood from which we can collect it. Once the stem cells are collected and frozen, the patient gets high doses of chemotherapy, and then the stem cells are returned to the patient after that to help the bone marrow recover appropriately. That, depending on the disease for which the transplant is given, depends on what the likelihood of return is. There are some diseases such as diffuse large B-cell lymphoma, or other types of lymphomas. There's also like germ cell tumors, like testicular cancer. These can be cured with an autologous stem cell transplant. There are diseases like multiple myeloma for which the likelihood of a cure from an autologous stem cell transplant is quite a bit lower. But what the auto transplant allows us to do is it really allows us to maximize the amount of chemotherapy we can give someone and helps them recover by giving these stem cells back. In terms of the question about whether we kill the stem cells that are in the marrow product before infusing it, they've made attempts to try to do this, especially with in the setting of lymphoma, where the cells can be identified and removed with sometimes with an antibody, with some type of procedure. And they've actually found that the removal does not make a big difference in terms of the ultimate outcome. So even though it's possible to remove them, it probably, the ability to remove them with such a high degree of accuracy is very low. And the problem is a lot of times if those cells are still there, they may also still be in the patient. So you don't gain a lot by actually cleaning out the graft, as it were, as compared to not cleaning out the grafts. And you can lose a lot of the stem cells when you clean out the graft, which you don't really want to do because you want all those stem cells to be able to go back into the patient. An allo transplant, just to complete that train of thought, is a transplant from somebody else. And an allo transplant relies on the new immune system going and attacking any bits of cancer that are left behind in the person getting the transplant. So what would happen is if we have somebody who has acute leukemia, they get treated for acute leukemia, and from everything we can tell it goes away, then what we do is set them up for a transplant where we find a donor who who is matched based on looking at HLA markers, which are a set of markers in our body that helps us identify us as us and other people as other people. And what we can do is once we've matched that, we can collect their stem cells, and then the patient, so the donor gets the stem cells collected, the patient's getting chemotherapy, and then we give the stem cells from the donor to the recipient or the patient. And that, number one, it does allow us to give higher doses of chemotherapy, but more importantly, is this immune system coming from somebody else will go in and recognize that whatever the leukemia is or whatever type of cancer they have, it doesn't really belong there, and it will start attacking it. And that immune effect is actually what helps the disease stay under control, much more so than the high doses of chemotherapy. Of course, that type of transplant is also fraught with a number of different complications, because even though this immune system, we want it to go and attack the leukemia cells or the bad cells, sometimes it's unable to differentiate what the bad cells and the good cells are, and it can attack somebody's body, which is called graft versus host disease, and can be a very significant complication.
Ready for your next question? Outside of stem cell transplant, are there any treatment options for AML and or ALL on the horizon or in development you are particularly excited about?
Mm-hmm. Well, thank you very much for this very interesting question. Certainly, there are a lot of new drugs available. In fact, over the past 3 years, where our options for standard treatments for leukemia were limited to a few drugs, talking about 3-4 drugs at the most, there are, over the past 3 years, 8 new drugs approved by the FDA for treatment for acute myeloid leukemia. And many of these drugs are what we consider targeted therapies, which means that they target particular genetic change in particular type of leukemias, producing an improvement in the responses and better survival outcomes, and more importantly, providing better options for improving the chances of the patients getting cured for acute myeloid leukemia. The same principle occurs in acute lymphoid leukemias or acute lymphoblastic leukemias, which is another type of acute leukemia or malignancy, where the use of new drugs, specifically antibodies against markers that are expressed in the lymphocytes of patients affected with acute lymphoblastic leukemia, are able to dramatically improve the response in these patients. We offer patients with acute lymphoblastic leukemia with conventional treatment options, and the responses are always in the rate of 80% or so, which means that among 10 patients that we treat with the same treatment, 8 patients will respond, to the point that if we add those options, the responses are a lot more higher. And more importantly, the responses are not only in the upfront setting, talking about the first chemotherapy option we offer to the patients, but when patients do not respond to the first line of treatment, or when the patients have relapse. Relapse means that the disease was controlled for a certain time and eventually the leukemia came back. And sometimes the leukemias can come back after a few months. Sometimes the leukemias can come back after a few years. So for these particular scenarios that historically were very pessimistic because we didn't have better treatment choices, right now we have the options to improve the responses in patients that are in relapsed leukemia towards responses up to 50%, 60% of cases, for which these patients can get the option for responding options for having better quality of life, and more importantly, to consider transitioning then to transplant in case they didn't receive transplant in the past, for the possibility of them getting cured for the disease. Certainly, we can talk about different treatment options one by one. I certainly would like to know from the audience if they are interested to hear about a few of them. Until there is another question, let me just give you one medicine. There is this medicine called gilteritinib. This is a pill, and it's a medicine that targets a mutation in AML called FLT3 or FLT3. It's a mutation that is quite common in patients with acute myeloid leukemia. Conventionally, this type of leukemia expressing this marker, FLT3, is historically associated with very bad responses to conventional chemotherapy. Interestingly, since 2017, we have this drug that is called midostaurin. Is a little bit different than gilteritinib, that in combination with standard chemotherapy, it dramatically improves the responses of patients with AML carrying these mutations. However, if the patient does not achieve those goals, talking about they are not in remission, the patient relapses after the first line of treatment, gilteritinib provides an excellent second line option for patients who still carry the AML with the FLT3 mutation. In those particular scenarios, the treatment is impressive because it achieves excellent responses, and more importantly, it helps these patients to accomplish the possibility of getting a transplant very soon. What I like the best from this drug, specifically the gilteritinib, is that patients are still very functional. Remember, this is a pill. It's not the conventional intravenous chemotherapy where the patient is in the hospital for weeks and weeks, extremely sick, no hair, vomiting all the time, and having a significant risk for infections. I have the experience of patients taking this pill with relapse disease that were able to continue working while we were working on transitioning then to transplant options. So they were having this excellent interval of time where they were able to take the pill, stay at home, enjoy their life, working as much as possible until they are ready for other potential interventions, for example, stem cell transplant. So it's really changing. I mean, these new drugs are really changing the paradigm for treatment of AML, and we are certainly, Dr. Palmer and I, very excited to open more options like gilteritinib for patients with acute leukemias. That's certainly something that we are looking forward to and working on opening more clinical trials in this particular group of diseases. Mm-hmm.
Next question. Is there an age-related risk in leukemia? For example, the younger the patient, the higher is the risk of it coming back.
Mm-hmm. Yes, Jeanne, do you want to answer this question?
Sure, I can tackle this one. So with acute leukemia, when we try to define where the risks are, there's multiple different risks, and they all can be sort of analyzed separately. So in terms of the risk of age, we know that patients who have acute leukemia who are older tend to have more other conventional risks, which I'll talk about in a little bit. However, these conventional risks, some of these risks that we can identify, and when we talk about the risk of leukemia, we really are looking at what is the possibility that the leukemia is going to come back or not be able to be effectively treated. But when we look at these risks, I think patients who are older tend to have a higher likelihood of having some of these risks as compared to somebody who is younger. So that does mediate an age-related difference in risk. Also, since older patients sometimes can have more comorbidities, it does make it more difficult to be able to pursue aggressive therapy. However, as we see more and more patients who are older being in better and better health and maintaining their health better, that becomes less of a concern. And so when we look at the risk of acute leukemia, the risks are based on several different things. I think one of the major things that drives risk is something called cytogenetics or chromosomes. So these are changes in the genes that happen as a setting of having leukemia. So if somebody says, oh, you have this chromosome abnormality or this, genetic mutation, that does not mean it's a mutation that you're going to pass on to your children or that somebody's passed on to you. These are mutations that occur as the disease forms. So certain mutations are associated with a disease that's harder to treat and has a higher risk of relapse. There's also, and that's what we call a karyotype or chromosomes. And the best sort of comparison I can have is if you think of a woman who's pregnant and gets an amniocentesis to see whether there's Down syndrome, they look at the chromosomes for that. So this is just a way of looking at the genes. There's a more specific way to look at the genetic material, which is what detects things like the FLT3 mutation that Dr. Arana Yi was just talking about. And that allows us to do a much deeper view or a much deeper look on patients' leukemia. And we know that there are certain mutations, for example, the FLT3 mutation, there's P53 mutation, a lot of other different mutations. And we know that some of them convey different risks. In terms of certain mutations suggest that somebody's going to have a harder time getting their disease into remission, and the disease has a higher likelihood of coming back. Now, on the converse side, there's actually some mutations that are good risk and mean that there's a higher likelihood that we'll actually be able to achieve a complete remission and maintain that complete remission with standard treatment. Sometimes these mutations may also identify targeted therapy that can be used. So, for example, that FLT3 mutation, which we know conveys a higher risk, also is associated with being able to use a drug like gilteritinib, which targets it and can be a very effective treatment. Other such mutations are IDH1 and 2. So these, again, this is a bunch of alphabet soup, but certain mutations, there's pills that will actually target that mutation and can be used to treat the disease or to treat the underlying disease. So that's a really long-winded answer about the risk of age and acute leukemia, but I think to understand how we assess that risk, it is important to understand that there are different factors that convey risk inherent to a person's leukemia. And then there's different factors in terms of age and other medical problems that a person can have that can impact how well they will do with therapy and whether they'll have other complications associated with it.
Thank you very much, Dr. Palmer. I just want to point out something that is very easy to understand as well. So acute leukemia is a disease classically of the elderly. If we review the epidemiology of acute leukemias in the population in general, the vast majority of the patients affected by acute myeloid leukemia are in general older than 60. This doesn't mean that a patient with 20 years old or 15 years old or children are not affected by acute myeloid leukemia. But if you review the majority of the data that we have, many of these patients are elderly. And as Dr. Palmer pointed out, patients carry different gene mutations that could be associated with different prognosis and outcomes. The more genetic changes, the more chromosomal changes, the more complexity the patient has in the samples of the acute leukemia, the chances to respond to the conventional treatments are certainly less. That's certainly an important principle to understand. Yes, leukemia, we can determine that the approach of leukemia varies according to how old is the patient. It's certainly not the same to treat a patient, a 20 years old patient with acute leukemia versus a 70 years old patient with acute leukemia. very likely, even if they have the same name of the disease, the biology, the behavior of the leukemia in a 20 years old is not the same as the behavior of a leukemia patient in a 70 years old. The options for treatments are different as well. It's not the same to offer chemotherapy to a 20 years old because 20 years old patients are by definition more fit, more energetic. They do not have all of the medical complications that a 70 years old patient can have, for which the chances of having excellent responses and not significant complications to intensive chemotherapies is not as bad as offering the same treatment to a 70 years old patient. So when a patient is older, talking about 70 years old, 80 years old, 65 years old, we have to be very wise in terms of choosing the best treatment options for them. And not only taking in account, as I already mentioned, other medical problems that they could have. Many patients have diabetes, hypertension, heart disease, etc., but also taking in account the biology of these cancers, because there is a group of patients that are elderly who develop acute myeloid leukemia, and they have previous history of other cancers. For example, they developed breast cancer 10 years ago, or they had lung cancer and they received treatment for lung cancer, or they had prostate cancer and they had radiation, and eventually 10 years after they develop acute myeloid leukemia. So it's not the same to treat this group of patients compared to a younger patient with a brand new leukemia and not history of cancer. We know that those cases are more difficult to treat because conventionally they don't respond to treatments, but right now, thankfully, we have a lot more options with excellent responses and great chances of curing the leukemias with the right treatments. So the second point that you mentioned, younger the patient, the higher the risk for leukemia coming back, is true. Certainly, because the expectation is that this 20 years old patient is going to survive longer as a consequence of the treatment. Chances are that at some point the leukemia might come back. And that's why we have statistics. For example, we define that the patient is cured if after 5 years there is no evidence of leukemia back again. It's not the same principle that we can apply to an 80 years old, because maybe the patient that is already 80 years old with leukemia is not going to survive longer, not necessarily because of the leukemia itself, but because of other complications, other comorbidities, for which the chances for having leukemia coming back in younger patients will be always there and will be always a concern every time we follow up a patient that is young, treated with acute myeloid leukemia. In elderly patients, in general, the expectations are a little bit different towards, yes, curing the leukemia, but second, to try to improve the survival as much as possible, and third, to provide the best quality of life. So if the patient is going to live with leukemia, to try to make sure that the patient is able to enjoy life with other people, with the families, able to do some activities, for example, traveling, returning back, going to the cancer center only for a limited period of time because they need to spend time with their loved ones, etc., etc. I hope Dr. Palmer and I have answered your question. Thank you very much.
Okay, we have another question. When a patient with myeloma has an Auto Bmt under the oncologist's recommendation, does that patient have maintenance chemotherapy forever? If not, when does the patient stop and are considered cured under stringent remission? Do you perform CAR T cell therapy for ALL?
So there's a couple of questions there. The first one with regards to myeloma, auto transplants, and persistent chemotherapy or maintenance treatment. That's something that I think is it's hard to really define where the endpoint is for it. And I think it really does also depend on the physician treating the patient. I think when we look at what the role of maintenance treatment is for myeloma. And I don't personally treat a lot of myeloma, so I don't want to speak too strongly about that. But I know that a lot of times it is continued as long as it's tolerated and there's no evidence of progression. But I also know that more recently, there's actually, I know our group here looks at this a lot as to whether they were able to really achieve a very, very minimal amount of disease, like a minimal residual disease negative state. So they can actually, because our ways of detecting any evidence of disease have become so much better, we're actually able to really detect very small amounts of disease, and that can help us determine who we think may be in a remission that will last a long time versus not. But I think that in terms of the duration of the maintenance therapy, that's very, I think, sort of an individualized approach that is a shared decision-making process between the physician and the patient. So there's really not, I think, a hard and fast rule about what exactly should be done. And then in terms of what defines a stringent remission, I think we are still trying to understand that exactly, or understand that more completely, and try to understand at what point do we really think somebody's achieved enough of a response that we feel like they probably won't relapse. Unfortunately, that's a really hard one for almost any disease. Even if somebody's had a bone marrow transplant and it looks like they're in a very good, had a very good response, and with all of our methods of detection, we can't see their disease anymore, it's still possible for it to come back. So that's a little bit trickier to answer, and even harder for multiple myeloma, which again is a disease I don't routinely treat. In terms of CAR T-cell therapy for ALL, CAR T-cell therapy is a new type of treatment that uses immune cells to treat cancer. So if you'll recall, when I was talking about allo transplant, the benefit of allo transplant is this new immune system that will go and attack cancer because it recognizes it as something that doesn't belong. We've tried to hone in on that and to actually find specific markers on tumors that we can say, okay, well, if we make a cell that goes and attacks that marker, it will kill off the leukemia. And so one cell type that they do that with is a cell called T cells. Now, T cells are part of the immune system. They help fight off infections. They help generate responses to vaccines. But there are a subset of T cells are called cytotoxic T cells, and they're basically like killers. So they have a receptor, and if the receptor they have something on the surface that will recognize different proteins. And if you have one that says, oh, I recognize this specific protein, it will go and kill that cell through a variety of different mechanisms. So these CAR T therapies, what they do is, instead of just hoping that the body generates the right cells that will go and attack these bad cells, is they actually engineer them so that the part of the cell that recognizes what it needs to attack is very specific. So they all recognize the same marker. They all recognize the bad thing that needs to be killed. And so the CAR T cells, for example, for ALL, are going after CD19, and CD19 is a protein that's on the surface of leukemia cells, acute leukemia cells that are acute lymphoblastic leukemia. And this also, the CD19 is present on some types of lymphoma. So it's these CAR T cells, or these immune cells that go in and specifically kill off a certain type of cancer, are actually currently FDA approved for treatment of acute lymphoblastic leukemia in people who are under 26 years old. They're also approved for diffuse large B-cell lymphoma, which is a type of non-Hodgkin's lymphoma, and recently achieved approval for mantle cell lymphoma, which is another type of non-Hodgkin's lymphoma. We have done CAR T-cell for diffuse large B-cell as well as ALL in people who are under 26. Here, we are also doing a lot of clinical trials that are utilizing CAR T cells for other things, such as multiple myeloma. There's actually a CAR T cell product that will be approved probably in Q1 of 2021 that is a cell that's designed to kill off myeloma cells that we've seen some really nice responses with. We've had it in clinical trials here. And they are doing also clinical trials using these immune cells that will recognize different types of cancer, solid tumors even, which is really exciting stuff. I think that CAR T cells, are a very exciting new line of therapy. They're really trying to harness the benefit of the immune system. They try to maximize the benefits of a transplant without having some of the negative side effects, since these cells will just recognize tumor cells. They won't recognize good cells or any other cells. Also, somebody doesn't actually need a transplant to be able to get CAR T cells. Hopefully that answers the question.
Okay, next question. The question is about MDS. I was diagnosed with it earlier this year. The only treatments I have received so far is Neupogen and ARNS injections every 2 weeks to try to avoid transfusions. Is there something else that might help? I'm 73 years old.
Mm-hmm. Thank you very much for your question and for sharing your personal experience with this medical condition. To answer your question in more detail, I would like to point out that MDS, the same as acute leukemias, are a group of diseases. It's not only one disease. It's not the same to treat a patient with MDS versus another, because the spectrum of the MDS might be different. The treatments that I am reading right now, which is the Neupogen and ARNS that you are receiving, are most likely a treatment that is for patients with low risk MDS. So when I mention about this MDS, we are talking about a different group of disorders. I already say so. But for us to determine what is the best treatment interventions, we have categories of MDS. We have MDS that are, as I mentioned already, low risk, which is specifically the combination of certain clinical combined with some laboratory parameters that tell us whether the patient is high-risk disease, intermediate risk disease, or low-risk disease. So in general, we consider that patients should be on chemotherapy, talking about medicines to improve the blood count numbers, to cure the disease, when the patients have, in general, high-risk disease. For low-risk disease, in general, the treatments are more towards supported care. And very likely, the patient that asked this question is, in general, receiving these treatments because very likely the patient is already receiving transfusions or very close to receive transfusions. Am I right? If that is the case, the injections that you are getting, specifically the ARNS, is for improving the red cell counts. The responses to RNS in general are in the rate of 30–40%, which means that if I offer the same medication to patients, 3 or 4 of them out of 10 are going to respond to the treatment. Therefore, there is no need to change the medicine because the medicine is doing its job, which is prevention of transfusions. Neupogen is a medicine that helps to improve the white cell counts. So very likely for the case that we are reviewing, the white counts are low, and as a consequence, we need to improve the white counts with the addition of this Neupogen. And in general, I start using Neupogen when one of the elements of the white counts that is called neutrophils are below 500. I already mentioned at the beginning of the presentation that when the white counts are too low, the risk is for the patient to develop serious infections. And now with these COVID times, where a lot of people are concerned, afraid of COVID, certainly having a decent amount of white counts is important for prevention of infections. So the treatments are directed towards those goals, not necessarily curing low-risk MDS, because patients with low-risk MDS have, in general, excellent life expectancies. But more importantly, the focus is in prevention of the very low blood counts that they could have. If RNS is working, perfect, we continue RNS. If RNS is not producing any side effects, which very likely the doctor that ordered the medication to the patient review with the patient before, excellent. But if the patient is not responding to Aranes, if the patient is failing Aranes injections because the doctor increases the dose, gives the medicine more frequently, more often, and the blood counts are not responding, there are right now FDA-approved medications for these situations. And there is this medicine called luspatercept. It's a subcutaneous injection every 3 weeks that we use for patients that are not responding to Aranes injections. The responses are, I always say this to the patient, we don't have perfect drugs. The responses are approximately between 30 to 40%, but this is for the group of patients that are not responding to Aranes injections, for which with this new medication, we are providing better options compared to transfusions to prevent the need for too many transfusions in the patients. And right now is something that maybe the patient that asked this question should ask to the doctor that is treating him or her with the medication and see whether luspatercept is an excellent option in case Aranes is no longer a great treatment for the MDS that the patient is having. As Dr. Palmer says, there are right now clinical trials for low-risk MDS, and there is a clinical trial that is already ongoing with the use of telomerase inhibitors. This is the medicine, the name is imetelstat. It's not FDA approved yet, but it's certainly another potential option that is currently in phase 3, which is like before FDA approval for patients that have low risk MDS and are transfusion dependent. I just want to point out the reason why it's important for patients not to receive too many blood transfusions. The risks are related to significant iron accumulation in the body when patients get too many blood transfusions. When patients get transfusions once a week, twice a week, 3 times a week, there is a lot of iron that gets accumulated in the body, and this iron, unfortunately, can produce significant damage to different organs and systems. And the organ that usually is more affected is the liver. So patients can start having liver problems as a consequence of too many iron in the body, as a consequence of too many transfusions. I have a case that, of low-risk MDS that eventually developed cirrhosis simply because the patient was getting too many transfusions. And it's something that the hematologists, the doctors that are treating patients with low-risk MDS would like to prevent. Thank you very much for the question.
Okay, next question. How significant is the level of concentration of nucleated red blood cells per 100 white blood cells in the peripheral blood?
So I can try to tackle that one. I'm guessing that whoever asked that question probably gets their blood work done at Mayo Clinic, because we always end up reporting the nucleated red blood cell count. So red blood cells, inherently, the red blood cells in our peripheral blood usually do not have nuclei in them. Nuclei is the center of the cells that contains all the DNA. So what happens with red cells is as they grow up in the bone marrow, they actually have a nucleus that helps them kind of go through the different steps of becoming a mature red blood cell. And then once they become mature, they get rid of the nucleus and they get released out into the blood. In some cases, and this is not all of them, but in some cases, let's say somebody is destroying a lot of red blood cells or losing red blood cells, then their marrow is overproducing and sometimes ends up kicking out cells earlier on in the process, in which case you may sometimes see nucleated red blood cells in the peripheral blood. Now, more commonly than not, and it's a kind of an anomaly of the lab here, they always report out nucleated red blood cells. And frankly, usually when I see this, because I see this in a lot of my patients, it's actually not a reflection of somebody losing blood or destroying blood. I'm actually not 100% sure why that readout comes, because it doesn't seem to correlate with any specific disease or any specific findings. So the nucleated red blood cells that are reported, again, unless there's a marked change from one to the other, or unless there's other clinical things going on that are concerning, I usually don't pay that much attention to, frankly, just because they do seem to be reported here, and I generally haven't been able to find any correlation with anything that's clinically important to a patient. It's not a totally satisfying answer, but hopefully it can provide some reassurance that if you start to see those counts in there, it's always important to ask your doctor in case this is something, but more times than not, it's not something that is terribly concerning.
Yeah, there are certain scenarios where the concentration of nucleated red cells are important, not necessarily in leukemias, which is the purpose of our conversation here, but in general is, for example, when patients have these particular disorders, for example, like hemolytic anemias, when there is a sudden destruction of the red cells. In general, the bone marrow that is producing normal cells start to produce more red cells. And as a consequence of that, we do anticipate an increase in the nucleated red cells as a consequence of the more production of a little bit more immature red cells as a consequence of the acute hemolysis or destruction of these cells. Another important setting is if the patient is massively bleeding. For example, a patient is involved in a car wreck and as a consequence is bleeding profusely, and the patient goes to the hospital and need a lot of transfusions. These are in general settings where the patient is obviously critically sick, and when we report in the regular blood counts, the hemoglobin, the hematocrit, and then we will see in general these reports. In addition to this setting, I would not, as Dr. Palmer says, worry too much about the presence of nucleated red blood cells, because for us, more important than these numbers is the current numbers, the red cell counts. Are you anemic, or on the contrary, your red cells are too high or too low? Because many times we know what is ongoing in the patient case. And remember that many times when we treat patients with leukemias, we already explore what's going on in the bone marrow. Many patients that we treat here with transplant, with chemotherapy for acute leukemia, chemotherapies for MDS, they already have bone marrow biopsy. So we already have the gold standards in terms of knowing what's going on with the patient, for which studies like the presence of nucleated red blood cells are, I would say, a little bit secondary, not necessarily the primary study.
Okay. Next question. Is it important for a patient with multiple myeloma to take in Alendronate continuously?
Right. Well, the conversation today was related to acute leukemias. I can certainly answer this question because as a part of our training, Dr. Palmer and I, we have, experience in treating these patients, although it's not part of our level of expertise. But the use of biphosphonates, which is where Alendronate belongs to, are medications that are very important in preventing skeletal related events, talking about bone fractures or problems associated in the bones related to multiple myeloma. So the use of Alendronate and other similar medications are recommended and part of the standard when patients have diagnosis of multiple myeloma. The guidelines for treating with Alendronate or other similar medications is for approximately 2 years. After 2 years, the recommendation to prolong the use of Alendronate or other related medications is really individually based and up to the clinician. But in general, the guidelines do not extend the use of Alendronate beyond 2 years after the diagnosis of multiple myeloma. Jody, I think there is another question that George asked.
Sure.
And I was wondering if you can read that, so maybe Dr. Palmer can answer that question.
Sure. Yeah. Can we engineer DNAs or RNAs of cancer cells to present surfacing antigen of these cancer cells so that we are able to produce or manufacture antibody for helper T?
So I'll try to answer this question. So I think, and hopefully I'm right in trying to figure out to make sure that I address the question in a way that answers it. But when we try to engineer a cell, like one of the T cells, as I said, or the immune effector cells, and now they're doing other types of immune cells such as NK cells and stuff, what we do is they use a viral DNA, go into this T cell so that the T cell expresses something on its surface or has part of the machinery necessary that it will recognize a very specific antigen or target, at which point that T cell knows to go and kill that target. And so that is how it's being done now to take these cells and train them to go and kill off these cells. And that's the immune effector cell that we've talked about a little bit earlier during this time. Now, I think in thinking about the antibody that we use to help there is an antibody therapy, they're called BITE therapies, and there's actually 2 antibodies that are attached to one another. So for example, for acute lymphoblastic leukemia, you will have an antibody that goes against CD19, which is a marker that's on acute leukemia cells, and another marker that goes on CD3, which is a marker for T cells. So that will get both the helper T cells, which are CD4, as well as the cytotoxic T cells, which are CD8, and it brings the T cells over to the leukemia cells so that they know to go over there and kill them. So in that case, that is an antibody that is produced, or an antibody that is used to harness the effects of T cells to help them go kill leukemia. Now, the tricky part about finding a specific marker on a tumor cell that we can engineer or train these T cells to go and attack is that we need to make sure that marker is unique to the cancer cell. So one of the challenges to finding these markers is if you say, well, geez, this protein is on the surface of this type of tumor, say as a liver tumor, but that marker is something that's on healthy liver cells. You can make a cell that will go and attack everything, the healthy cells and the bad cells, in which case then you might end up with liver damage or something like that. So finding these real specific markers that we can go and attack a tumor cell and not attack healthy cells is the challenge that we're facing as we try to produce more and more of these immune effector cells.
Absolutely.
That helps answer some of that question.
Right. So George, thank you very much for this question. It's really a complex question to answer, but certainly what we need to determine here is what strategies we can do to target DNAs or RNA. As you have heard from Dr. Palmer previous answer for the CAR T cells. CAR T cells are essentially therapies that are directed towards targeting cells. Leukemia cells primarily. So we are talking about the cell that has different organelles, the cell that has DNA, RNA. So you are talking about structures that are a lot more smaller, kind of like we are unable to see under the electron microscopy, for example. You are targeting like teeny tiny mutations in the DNA. And we have to remember that we all have DNA. Our bodies have DNA, RNA. So we need to be extremely selective to the DNA and RNA that is abnormal, that is responsible for the development of cancer, in this case, leukemia. And maybe you are aware of the recent Nobel Prize winners. And one of the winners is essentially a group of doctors that developed this new technique that is called CRISPR. I would spell it because with my Spanglish, unfortunately, I'm not very good at it, but it's CRISPR, which is a relatively novel technique that it's certainly very promising in curing not only different types of cancer, but different type of genetic diseases. And it's certainly a very innovative technique where through genetic engineer, we can manipulate the abnormal DNA and RNA and fix where the problem is. So if we have a genetic mutation responsible for this type of leukemia, we can fix the mutation, and as a consequence, we cure the problem, as simple as that. And certainly we can manipulate the DNA or RNA for this DNA and RNA that is abnormal to be prone to become more affected by potential immunogenic targets, talking about to make the cell more susceptible to the normal attack of the patient immune system. So it's essentially very promising. When I reviewed this topic a few months ago, we were very excited that this could potentially change, again, the paradigm of treatment of many disorders, not only cancer, but many genetic disorders in humans, for which certainly we need to involve not only strategies towards therapeutic options, talking about clinical trials for different diseases, but also the ethical aspects of that, which means that, what genes are we going to regulate, what other areas in the DNA, RNA are going to affect, not avoiding the possibility of potential complications in this group of patients, because you affect a portion of the DNA and certainly you might have complications in other structures of the DNA that are for normal function of the cells. You see what I mean? There were some experiments done in cancer with this technique or the CRISPR, and from one side we cure the genetic problem, but eventually the patient developed later other complications that were as a consequence, kind of like unexpected consequence of fixing the DNA problem. So we need to be still, very cautious about these possibilities. Certainly, it's a very exciting time for discussing about clinical trials, doing this in leukemias. But again, these are all under the umbrella of clinical trials. We need to develop early phase, providing the safety of these studies. We need to have ethical discussions about whether it's worth it to consider this option for this group of patients versus not these other patients. The funding aspects as well. I mean, the money that we have, what are we going to do with that? I mean, are we going to do studies for leukemias or maybe lung cancer or other different diseases? But I think this is a excellent question that hopefully we will be able to answer, in the next, few years. But thank you very much.
Okay, next question. How do you treat pancreatic myeloma having a 3-centimeter tumor? Do you treat as pancreatic cancer by Whipple surgery?
So again, I don't treat a lot of myeloma, but I would say there's sort of a general concept of extramedullary bone marrow diseases. So for example, acute leukemia can be extramedullary, meaning outside of the bone. And so when you talk about a plasmacytoma, a lot of times when you have these like outside of the bone marrow collections of cells that normally are problems in the bone marrow, you treat them a little differently than you would a solid tumor. Because usually if you were to have a plasmacytoma, which would be a myeloma tumor someplace, you probably have myeloma elsewhere in the body, in which case you'd want to use more systemic therapy or therapy that you take either intravenously or by pill to treat it rather than to actually surgically remove it, because any type of surgical procedure requires a lot of recovery, and that would delay treatment of other parts, cancer elsewhere in the body. So my guess would be it probably would not be treated like a pancreatic cancer in terms of having a Whipple, and it would probably be treated more with the same chemotherapy that would be used to treat the disease in the bone marrow itself.
Okay, next question. As part of the answer, quote, clinical trials were mentioned. How can I find out more information about that? My question was about MDS treatments.
Thank you very much for the question. There are different resources that you can use to get access to clinical trials in MDS. There are two nonprofit organizations that see cases and can provide information about clinical trials. I'm going to mention a few of them. One is the Leukemia and Lymphoma Society. All you need to do is to type in Google, in the computer, about this nonprofit organization. The others are more directed towards MDS, and there is this institution called MDS Foundation. Mayo Clinic is MDS Foundation Cancer Center of Excellence, where we have access to clinical trials in MDS. And the third is to another nonprofit organization that is called Aplastic Anemia MDS Foundation. These are three different organizations where you can get access to clinical trials for MDS patients. The other option is obviously contacting your doctor. Over here, we have the option for clinical trials. Unfortunately, in MDS, as I already say, MDS is a very heterogeneous disease. So we have different types of MDS with different prognosis. For now, we are focusing on high-risk MDS, but I know that there is an ongoing study with imetelstat in cancer centers, and we certainly might consider participating on this clinical trial. As far as I am aware, we don't have this trial available in other cancer centers in the state of Arizona, but is something that we would like to consider as well for patients with low-risk MDS. If you have certainly additional questions, you can contact the Mayo Clinic to see whether, in addition to the treatments that you are getting, there are other potential options that we can certainly try.
So we don't currently have any more questions. Please, if you do have any, drop them there in the chat box or the question and answer box, and we'd be happy to answer them. We just have a few more minutes left of our session today. I've also posted in the chat, if you would take a look, there is a link in the chat to fill out the survey for our symposium this year. We would greatly appreciate the feedback. It is our first virtual symposium, so any feedback will be greatly appreciated.
Mm-hmm. I just want to ask the question to Dr. Palmer here from the Mayo Clinic resources, how patients can get access to clinical trial through the Mayo Clinic website. Is there any way how to do that? Mm-hmm.
I'm actually, I'm not sure. I know that I've definitely had patients who reach out to me specifically because of clinical trials.
Mm-hmm.
A lot of times what helps is if you go to clinicaltrials.gov, which is a website, and I can actually just put it in this chat section here. And what clinicaltrials.gov does is actually you can put like MDS and you can put states or whatever, and open trials, and it kind of helps hone down on what different trials are available in different places. And then from there, they actually have contact information for all the sites that have the clinical trials so that you're able to reach out to somebody and see whether you'd be eligible for it. I know that there is a way on the Mayo, probably on the Mayo website, and I should know this, but I don't actually have that specific answer. But there is probably a way on the Mayo website to identify which trials are open here specifically. I don't know, Jody, if that information, if you have it anywhere that could be provided to the panelists?
I can see if I can pull up the link right now for that while you're
Yeah.
finishing up.
Yes, I just want to mention something that we are doing is part of the working progress. Mayo Clinic works as a 3-site, so it's not only here, the location in Arizona, but also Rochester in Minnesota and Jacksonville in Florida. Our group, which is the Leukemia BNT group, are already having meetings, and we just had one a few weeks ago regarding improving the website, to make this website family and patient friendly for the patients with leukemias in general, MDS, acute leukemias, requiring bone marrow transplants, to get a very easy access through links or portals for clinical trials that are ongoing, not only here in Arizona, but also in the other 2 sites. So this is an ongoing process. We are certainly working actively on facilitating the search from patients when they ask these questions, which are very relevant. So hopefully very soon, it will be a lot more easy to navigate through the website portal for the patients requesting evaluations at Mayo Clinic to get access to clinical trials for MDS, but also for other medical conditions. Mm-hmm.
There's a question in regards to state of California, Silicon Valley clinical trials. So you can go on the link that Dr. Palmer provided right there in the Zoom chat, and you can search by, clinical trials at Mayo Clinic.
Right, so that link there is for the Mayo Clinic ones, but above that, the clinicaltrials.gov, that's a website that has clinical trials all over the United States. So what you can actually do if you go on clinicaltrials.gov is that you can, and actually if we have a few minutes, I can actually pull it up and share my screen. And so this is the website. And so let's say, for example, you want to do myelodysplastic or multiple myeloma. And then you can put the country, so United States. Then you can actually choose the state and even the city. So if you were to say California and search, then what it does is it lists all the different studies found for multiple myeloma in the state of California. And then you can actually put recruiting, so you can find out the studies that are recruiting now. And you always have to remember to press apply. And then, then you can say, okay, what criteria, and you can like age group, gender, study type, interventional, observational. So you can really, put in and get like this, that narrows that down from 431 to 66 studies in California. And this is looking at different studies and what they are. And then if you click on, for example, say one of these studies, what it will do is it will pull it up, and it will actually, say briefly what the study is about, who's eligible for the criteria. I'm sorry if I'm making, and then also contacts. So like this one, I'll tell you what the phone number and the email is of the person to contact. That might be able to help you get more information on the study.
We have just a very small amount of time left. There's one last question here that just came up. Do you have time to discuss it real quick? Mm-hmm. Okay. Can we speak about treatment-related AML, such as post non-Hodgkin's lymphoma treatment?
Mm-hmm. Yes, maybe 30 seconds. So this is the kind of secondary leukemias that occur in elderly patients, because they are already many times treated with other cancers. And certainly non-Hodgkin lymphoma is one of them. I mean, patients get lymphomas, get chemotherapy, radiation, sometimes transplant, and then they develop acute leukemia. This is by definition a high-risk leukemia. High-risk leukemia means that leukemias are not going to respond conventionally to standard treatments. For this group of patients, it's better to consider enrolling the patient on a clinical trial. But according to the biology of the leukemia, talking about the identification of chromosome changes, identification of molecular changes, talking about gene mutations, what we can do is to identify genes that we can potentially target with some medications. This way, we can offer the patient standards, talking about chemotherapies conventionally approved by the FDA in combination with targeted therapies. But the point number one will be the consideration for clinical trials.
Thank you. We're just about done here. Thank you all for your amazing questions. We really appreciate it. And please, again, fill out the survey if you do have time to do that. That would be great.